ये नजर आ रही है, ये 135 participants हैं and you can write something here. हेलो लिख दें, कैन यू हेयर मी वगैरह वगैरह.
हेलो हेलो
आइए.
आ रही है. Okay. Hello, can you hear me? Assalamu alaikum. Assalamu alaikum. Okay. Thank you. I'll join you in a couple of minutes. Right. Share screen on this one. Hello. Oh, yes. Uh-huh. Yes, yes. Right. Hello. Where can I communicate? Write it down.
किसी एक ने आपको जवाब दिया.
Okay. वालेकुम अस्सलाम. वो आवाज जा रही है ना? Okay. Zafar Abbas. Right. Okay. So writing anything? Right. Okay. Maida Makbul to everyone. Yes, sir. Can you hear me? Yeah. Alright. Okay. In case. Okay.
यहाँ से आपको पता लगता है कि आपकी आवाज जा रही है.
Right. Okay.
ये लगता है.
Alright. It says mute. Right. Okay. Let's get going. I think we've got a bit of time. I hope you are all safe in your places, wherever you are, and doing fine, staying safe. When you go out, as I mentioned earlier, go out, keep social distancing, and keep the masks on. Okay. We want you safe back here again in the near future, I hope. Right. So during the last lecture, we were discussing about the upper GI. We started with the esophagus, and usually the important question pharyngeal pouch, then the bird's beak appearance. It says your internet connection is unstable. Okay, I hope you can still hear me. Can you? We've got some problem with the internet here. All right. Okay. Right. What should we do now? Okay. Right. So we were talking about the important questions, and the other part is in the esophagus is GERD, gastroesophageal reflux disease, and carcinoma of the esophagus, as well as we discussed about hiatus hernia, both the sliding type and the rolling type hernia, and the mixed as well. Right. I hope you can still hear me. Yeah. Okay. Right. So after esophagus, I thought we'll discuss about the stomach. The important questions about stomach and duodenum are hematemesis. And patients comes to you in emergency with vomiting blood. And the other important question is that you might be asked that a 50-year-old gentleman comes in emergency with a severe upper abdominal pain. He also gets a history of NSAIDs intake for his osteoarthritis. Hello? Hello, can you hear me? Yeah?
Hello?
Hello, can you hear me? Yeah? Okay. Right. So what we need to do is, if somebody comes with severe upper abdominal pain, history of NSAID intake, and the history of tachycardia, pulse of 120 per minute, and also looking hypotensive, blood pressure goes down, 100 systolic. Examinations, it's got guarding and tenderness in the abdomen, the gastric region especially. Then the usual question asks, what is your diagnosis? So the diagnosis, usually they're talking about perforated ulcer. It could be duodenal ulcer or gastric ulcer. But at the same time, you should also do serum amylase and serum lipase to exclude pancreatitis. That's another condition in upper abdominal pain and acute cholecystitis. It could be due to gallstones. But here we concentrate on the stomach. Now, the most important thing about the stomach is the anatomy of the stomach, and pathophysiology of the stomach, and in anatomy. One of the questions was asked once, discuss the blood supply of the stomach. So as you all know, the blood supply of the stomach, if you look at that, where my pointer is, arrow is, that's the aortic hiatus in the diaphragm and the abdominal aorta, the big vessel, big artery that emerges from the aortic hiatus, and there is a celiac axis there. This celiac axis divides into 3 branches, right? And these 3 branches are, you can see that's the left gastric artery, that's the splenic artery, and that's the common hepatic artery. This splenic artery goes behind the stomach and supplies the spleen, the splenic artery, okay? And this common hepatic divides into right gastric and it goes up as a hepatic artery and divides into right and left hepatic branches. That's very important to understand. And on the lesser curve, this is the lesser curve of the stomach. This is the greater curve of the stomach. Okay? Now the right gastric artery anastomoses with the left gastric artery at the lesser curve. Now the most important part, which is usually asked in the examination when there is a hematemesis because of the posterior duodenal ulcer that penetrates into the gastroduodenal artery. Okay. Now this gastroduodenal artery emerges from the hepatic artery and goes beyond duodenum, behind the duodenum, and divides into Oh, oh, there's a little problem with the net. Yeah. Hello. Right, okay. So here we go. Right, okay. I hope you can hear me now. Right. Okay, so we were talking about this importance of gastroduodenal artery. It goes behind the first part of the duodenum, and if there's an ulcer that penetrates in the duodenum into this gastroduodenal artery, you can have massive bleed into the stomach. So from there, the ulcer is there, the back wall of the duodenum, and all the blood comes out, and you have massive hematemesis. Normally, the curve you get tonsillitis, the anterior one. But if the posterior duodenal ulcer, you get this massive hemorrhage. Okay. So that's all about the blood supply. You have three branches from the celiac axis. The left gastric, or common fatty right gastric artery, and the left gastric artery anastomose, splenic artery behind the splenic, behind the stomach, the spleen. Okay, and like gastroepiploid and right gastroepiploid, the anastomose at the greater curve. So that's the arterial blood supply, which is of importance. Uh, Now, if we uh, look at the blood supply once again, the lesser curve, at the lesser curve, the left gastric artery gets the right gastric on the little branch, uh, which is from common divides into a superior pancreatic duodenal, and good connection. See, Anida, with Baba share screen. Yes, sir. कौन सी अगर माइंड ना करें मैं आपको स्टेबल कनेक्शन दे दूं हाँ यार उधर मच बेटर किधर कॉर्नर यार ये निकाल देना नीचे से बैटरी चल जाएगी इसकी हाँ बैटरी चल जाएगी फुल है तो ये ले आना ये बैग भी है Okay? Right, okay. So that's about bit of a bother. And we've got the short gastric vasa brevia from splenic artery and the posterior wall of the body of the stomach branches from the splenic artery. Okay, so that's about the arterial blood supply. The venous blood supply corresponds to this, and the venous drainage goes into the portal vein, portal system. Now, uh, the other important part is the nerve supply. Now, there is an intrinsic nervous system and an extrinsic nervous system. The intrinsic system is Auerbach's myenteric plexus and submucosal Meissner's plexus, internal to the stomach. And the external is the vagal trunks, the anterior vagal trunk and the posterior vagal trunk. As you all know, vagus is the 10th radial nerve, which is basically secretomotor. It comes from the brain stem, and the fibers of the vagus, they condenses at the lower esophagus to form these vagal trunk. Now, the vagus is here to supply the gastric branches, and at the pyloric antrum, it divides into branches to make like a crow's foot. This branch, which further comes down, is called anterior nerve of Lethargy. You can find this picture in Bailey and Love, and I would advise you that when you read GI, you should at least go through once from Bailey and Love before spending all the time on Doger. So, so that's the supply, the anterior, and next comes the posterior vagal trunk. Okay, at the back of the esophagus, the posterior vagal trunk, the two vagal anterior and posterior vagal trunk supply the back of the stomach, gastric branches, and similarly the posterior nerve of Lethargy into the crow's foot, back of the pylorus. And there's a criminal nerve of Grassi at the fundus. All these branches supply the secretomotor functions, the vagal branches, okay? The functions of this is, as you know, secretomotor, they're sensory as well as effector, motor one, which causes a receptive relaxation of the stomach and the secretory activities. Right. Just to recap again, the vagal trunk, the vagus nerve, the anterior one, it comes in by the anterior surface. The posterior vagal trunk supplies the back of posterior side of the stomach. Okay, right, and here we are. The stomach, as you all know, is a reservoir for food, and where all digestion starts. And there are important cells. Yeah, it's okay now. Have you been to DME? Oh, right. Right. Okay. Now we got the gastric acid is produced in the stomach, as we all know, by a proton pump in the parietal cells, by these hydrogen and potassium proton pump, which in turn is controlled by H2 receptor histamine. Histamine is all produced by enterochromatin cells, ECL cells, in response to gastrin and vagus nerve. Now, the proton pump inhibitors abolishes the gastric acid production, whereas H2 receptors antagonists they markedly reduce the acid production. Now, the gastric mucus layer is very essential for the integrity of the gastric mucosa. The layer secreted by the mucus glands, the gastric mucus layer is essential for the integrity of the gastric mucosa. Right. Now, the other thing, this is about the anatomy and the nerve supply and the functions of the stomach, so much so. I, if you just do that, yeah, it'll be all clear. Yeah. Now, how do you investigate somebody coming with the gastric or duodenal problem, with the abdominal pain, bleeding, or you want to see the ulcer? The mainstay is the endoscopy, upper GI endoscopy, and you want to directly visualize with the help of endoscope, stomach, far down to the second part of the duodenum. And you got to take great care to avoid any complications, any perforation. Okay. Okay. I can hear a lot of noises here.
अच्छा मुझे बता देना यार.
Sorry?
Who is talking?
I don't know, somebody is talking. I can hear a lot of people. Yeah. Sorry about that. Okay. So endoscopy is the main step.
हाँ हाँ ये जो मेरा लेक्चर है वो है बोलो.
ये कौन बातें कर रहा है? कोई बातें कर रहे हैं सारे.
पीछे बोल रहे हैं लोग पीछे बोल रहे हैं.
सारे बोल रहे हैं ना, ये इनके वजह. Okay. Then after endoscopy, well, you can at the same time you can do an endoscopic ultrasound. You can transducer is attached at the tip of the endoscope, and you can at the same time do an endoscopic ultrasound, which is the most sensitive technique if you want to assess the stage of the tumor of the esophagus or the stomach. The other thing is, in addition to endoscopy, is you can do a CT scan or MRI, and this is also useful in staging of the gastric cancer, but it's less sensitive for other modalities than other modalities if you want to assess the liver metastases. The important investigation is PET scan. If you can do a PET scanning with CT, you combine that with CT, that gives you a very good picture. And also, you can do endoscopic, laparoscopic assessment of the extent of the tumor. If you want to see any involvement of the peritoneum, attach laparoscopic ultrasound. You can also evaluate liver metastases and if there's any lymph nodes involved. That's a picture of endoscope. You can see that's a big duodenal ulcer, and that's on the contrast examination. You can see the duodenal ulcer there. Now, usually the presentation is hematemesis, and what are the causes that can cause hematemesis? All these things should put in your mind. The most important is ulcers, and then come erosions and other causes. Ulcers, it could be esophageal ulcer, gastric ulcers, or duodenal ulcers. As you can see, the number here, duodenal ulcer bleeding. As I mentioned, gastroduodenal artery in the anatomy, that's usually the culprit. So maximum number of cases of epidermolysis are due to duodenal ulcer bleed or gastric ulcer bleed. Then comes erosions. Similar erosions could be esophageal erosion, gastric erosions, or duodenal erosions. Okay. Then we have malarialized tear, excessive vomiting. There is a mucosal tear at the lower end of the esophagus and stomach that can give rise to bleeding. And in case of uh, portal hypertension, patient can have an esophageal variceal bleeding and sometimes bleeding from the tumor. And there's vascular lesions in the stomach wall. It's very difficult to visualize these vascular lesions only when they're actually bleeding. But when they are not bleeding, it's very difficult to, even at endoscopy, it's very difficult to visualize where it's bleeding from. Okay, and there are the other causes. Now, this is a very important X-ray. It's an erect chest X-ray which shows, as you can see, uh, that's the white is the diaphragm, and you can see a black shadow under the white diaphragm is a gas. But normally you don't have a gas in the peritoneal cavity. If you see this gas, that's a bad sign. That means there is some perforation. It could be from duodenal ulcer perforation, gastric ulcer perforation. When you're dealing with perforations of these ulcers, if it's a duodenal ulcer, you can do a laparotomy. You close the perforation with a vicryl and put a little patch of cement. But if it's gastric ulcer perforation, it's very important to remember it's a gastric ulcer perforation. You don't just close the gastric ulcer. What you normally do is you take a full quadrant biopsy of the gastric ulcer, because why we take a biopsy for the gastric ulcer and not the duodenal ulcer? Because the gastric ulcer could be a malignant ulcer. So you want to make sure that you're not dealing with the malignancy. Okay? So if you see erect chest X-ray, if you see a gas under the diaphragm, so that's gas under the diaphragm. That means there's some perforation. It has come from the GI mostly. It could be from duodenal ulcer, from gastric ulcer perforation, could be from diverticular perforation, or any other perforation from like a typhoid perforation. Now that's a video gastroscope, as you can see. Video gastroscope. This is a camera stack. You can see the scope is hanging there, and that the screen, you can see that on this. That's the gastroscope with the biopsy channel. You can see this little tip. This is coming out. You can take a small biopsy of any suspicious lesion just to confirm it's malignant or not. Okay. Next one, that's the normal view when you go into the stomach. You see the stomach mucosal folds, and you can also see the duodenum. That's the duodenum. These are normal stomach folds. There's no ulceration in this picture. And these are different pictures showing different area, gastroesophageal area, the lower end of the lower sphincter of the esophagus. See the rest of the entering into the duodenum. That's the fundus area, and that's the entering into the duodenum, the duodenal view. And if you see this picture, I've shown you these before, I think. These are esophageal viruses, the lower end of the esophagus, and that's the banding. The band has been applied to the bleeding esophageal viruses to stop the bleeding. That's the, if you can look at, that's the bleeding vessel. You see this is a vessel which is causing upper GI bleeding. And these are the hemoclips applied endoscopically. You don't have to open up for all these things. Now you can do endoscopic control of the bleeding. You can inject adrenaline, other hemostat. You can cauterize it. You can apply hemoclip. You can also some availability of lasers and all that. Now these are the pictures of viruses in the stomach, in the fundus area. You can see the scope entering into the lower end of the esophagus, and that's the stomach area. And similarly, you can see these varices. Well, that's a gastric tumor. What you can do is you can look at the tumor, take a biopsy, and confirm the diagnosis, and you can go back to do a subtotal.
Video can be uploaded as well. Your video, if you want.
All right. Well, there's no need for that. Right. You can take a biopsy, and ultimately you can decide to do a radical gastrectomy or whatever is required. Now that's the hiatal hernia, which shows an ulcer in the hernial sac or Cameron ulcer. And these are the different grades of GERD, gastroesophageal reflux disease. What's the time, by the way?
5 minutes remaining.
5 minutes?
10:53.
Oh dear. I'm just rushing now. Different, yeah. Okay, different grades, A, B, C, D. That goes to severity. If you want to ask any questions in the meantime, well, I'm just pressing on. That's the bleeding area where the biopsy has been done, a white-based area. That's a stent. It is a stricture in the esophagus. You got these metallic stents. This is a palliative attempt. Normally you do esophagectomy, as I told you in the last lecture. Now that's a polyp that has been taken out endoscopically. Okay, and well, that's the CT scan. As you can see, that's the liver, that's the spine. You can see the ribs and the sides, and that's the stomach. That's the splenic area. That's the stomach. You can see this is a gastric tumor on a CT scan. That's the contrast within it. That's the aorta, by the way. Okay, and these renal vessels. That's the liver, right below the liver. That's the anterior. That's the posterior aspect. And you can see this on a CT scan showing gastric carcinoma from the body of the stomach. Now that's the PET CT. I was positron emission tomography combined with the CT scan. As you can see, this PET CT shows a gastric carcinoma. That's a plain CT. It's a plain CT, and these are the PET CT that shows the cancer, and also it shows the left cervical lymph node. Left cervical lymph node is called Burkhart's node, Trozier sign. Remember that, Burkhart's node. If you see, so every abdominal examination is not complete unless you examine the neck. So that's the important thing. The Burkhart's node. Okay. Now this is the endoscopic ultrasound. Okay. You can see the early gastric cancer on the endoscopic ultrasound, which is the mainstay of staging or evaluating the esophageal cancer. Okay, that's the picture. It shows that it's involved this area. You can also see all the muscularis, the serosa, all different layers all together. Okay. The other thing comes with the H. pylori infection. Okay. I think we just got a few minutes. If there's any question, please do ask. The Helicobacter pylori, you must have read it in medicine in greater detail. It is thought to be responsible for type B gastritis, peptic ulceration, and gastric cancer as well now. Okay. Uh, the infection is thought to be, the rate is inversely associated with the socioeconomic status. The poor the socioeconomic status, the higher is the infection rate of H. pylori and vice versa. So now we can eradicate this with the combination of proton pump inhibitors and some antibiotics. And you can have this erosive gastritis with the NSAIDs and can cause emesis. As we all know, the type 1 gastritis is an autoimmune thing, and it is associated with the development of pernicious anemia, hypoareclohydria, and gastric cancer can develop. Okay. Type B gastritis is a type gastritis with H. pylori. Most commonly, type B gastritis affects the antrum, and these patients are prone to peptic ulcer disease. That's the H. pylori gastritis. As you can see, the antrum, these are the area where there's a H. pylori infection. This area and that area there. Okay, you can do a biopsy, do a flow test, do a breath test to confirm it, and with a triple regime, you can treat it. All right. Okay. Okay. Thank you very much. I think so nice of you with all these net problems. We managed to have covered a little bit. We'll come back and complete this maybe next time. Thank you very much. Stay safe again. Okay. Thank you.